call in, but for the interest of time, I'm going to go ahead and just get started. For those who have called in, if you can just let me know if you can hear me or not. So good morning, everybody. I'm Janella Perucha. I am the CPQCC Program Manager for the Data Center. Just a few quick notes. Everyone who has called in, aside from the presenters, will be muted. So if you have any questions or comments, please post them in the Q&A section, which is located at the bottom of your screen. So we have a packed agenda today. So we're going to start off with an introduction from Dr. Henry Lee, who is our Chief CPQCC Medical Officer, and Dr. Priya Jagathisan, who is a neonatologist for Santa Clara Valley Medical Center and a CPQCC PQIP member. Both Dr. Lee and Jagathisan spearheaded this project. And then we will have 3 member hospitals who will present on their experiences with delayed cord clamping, starting with Sharp-Murray Birch, presented by Dr. Anup Patharia and Vivian Medicalzabal. Cedar Sinai Medical Center, presented by Christine Galsam, and then Adventist Health White Memorial, presented by Eileen Takashita. We'll have time for discussion where we can go over the questions and comments that pop up during the presentations. And then we'll finally adjourn at 11:30. So I'm gonna go, so Henry, I'm gonna go ahead and toss it to you. I'm gonna pull up your slides and then you can get started. Okay, so thank you, everybody.
Thanks, Janella. You hear me?
Yes, I can hear you.
All right.
I'm just pulling up your slides right now.
Sounds good. Yeah, thanks everyone for joining. And just in case we don't get a chance to later, I just want to acknowledge and thank Janella for her great work on this project. It's been like 2 years now, I guess, or even more than that, since we first started in this effort, and also for Priya for helping us to actually prodding us in the beginning to, first of all, collect data and help the state NICUs in this implementation process, not just for data collection, but for helping to do better in terms of DCC. Yeah, and thank you to all our panelists who will be talking today. I think it's been really beneficial to hear from different sites from the beginning of the project and ongoing to see what have been some solutions and ways that people have overcome barriers. So I think it's really a great aspect of CPQCC that we're able to learn from each other. So this is just a figure and showing the trends over time from since we started in 2016, the collection of these data. And just as a caveat, 2018 is the date that this year is the first one where the data collection became whole membership wide. Prior to that, it was voluntary, and many of you participated in that sort of pilot phase in that first year or 2 even, and that represented sort of more and more NICUs joining each, over time. But I think in the beginning we just had maybe around 40 NICUs that first year. And it increased to maybe about 60 that second year in 2017. So, but keeping that in mind, there has been a steady increasing trend in delayed cord clamping, as you can see over time. And this is just basically all CPQCC eligible babies. So this represents, not necessarily the well babies in your hospital, but babies, all the small babies, the preterm babies, as well as the big babies that happen to be in CPQCC data collection in your NICU. So I think that's encouraging, and there's still variation across centers, but this is a good sort of figure showing increasing implementation. So next, and then the red line, sorry, is umbilical cord milking, and that's remains relatively steady, but perhaps there's been a little bit of increase over time in that as well. That last dot is just this past month, which I'm sure is not fully complete in your data collection. And actually 2018 in general is probably sporadic in terms of depending on site, how far you're along in your data entry. So next slide. The other thing that, a big part of trying to do quality improvement in implementation work is having good data. And we recognize really from the beginning that this is perhaps a little bit different type of data item than others that might be harder to capture. And so we recognize there would probably in the beginning be a lot of missing variables. And so that was the case, but you can see there too, I think there's been some improvement over time, and we could probably still continue to do better. And there's previous webinars that have addressed this, people implementing data entry into their EHRs and so forth, and other strategies to try to make sure these data are captured. So we'll continue to work on that, I think. Next slide. This is a figure showing sort of a little bit of variation by hospital. So this is a distribution in each hospital's DCC rate among CPQC eligible babies. And so what you see here is that, there's quite a range. So I think it just shows that some hospitals are a little bit further along, and perhaps, and I know some hospitals had already adopted the practice prior to, 2016. So on the right side of the figure, you can see there are some hospitals that are achieving, almost 90, 100%, 80, 70 to 100%. There's like 8, 9 NICUs that are in that higher range. But the majority of folks are sort of, kind of either low or in the middle there. And so I think this is helpful to see perhaps where each hospital stands, wherever you're at, so that you can see what might be your goal. And then the next slide is showing something very similar in terms of missing data. So you can see that there's, so it's on this figure, it's better to be on the left side if you have less missing data, which is, let's say less than 10%. There's actually the large majority of hospitals are in that that leftmost box, which is great. So I think if your hospital's on the right hand side, then it's just a sort of call to try to help figure out to get better data collection. So those are all my figures that I have, and I think it's really encouraging to see the progress so far, but also recognize that there's a lot of work to be done, and so appreciate all the panelists helping as well in that regard today to kind of further the discussion. Just to note, since we started this sort of as a pilot in 2016, and it became sort of statewide in 2018. If you go on our report site, you can definitely see each hospital's your data and how you compare to the rest of the state. But it's in a relatively rudimentary table format that's not quite as robust yet as some of the other figures and tables that you can do with other quality measures that you have in CPQCC. And part of that is we just don't have enough data yet in order to sort of really get good trends and figures like that. We need probably at least 3 years of data. But over the next year, Beata Danielson, who does our report site, she's already thinking of how to implement some better figures and so forth for this measure, which will be similar to the other ones, but be patient with us because because of the relative newness of the data, it probably won't be quite as helpful as some of the other figures that we have. But the raw data will be there for your center as well as in comparison to other centers. All right, that's all I got, Janella.
All right, thank you, Henry. Okay, so I'm gonna go ahead and pull up Sharp Mary Birch. All right. If Dr. Catharia, if you're on the line, if you can go ahead and.
Sure, yeah, you're kind of going in and out, but I don't know if that's just my signal or not, Janella, but can you hear me fine?
I can hear you perfect.
Okay. So yeah, thanks Henry and Priya and Janelle for inviting us. Actually, I think this came through one of our SHARP other hospitals at Chula Vista. So Vivian, I know you're on the call as well. So if you have anything to comment, let me know. But I think the purpose of this is to sort of share where we're at with our clinical data. So I have a big interest on the research end, and Henry and Priya know this well, but I'm really going to focus on how we brought delayed cord clamping and cord milking to our site. So I'll sort of give some background, and I'll share our three sites at our SHARP-wide system where we're at with implementation. So you can go to the next slide. Okay, so here's our history. I came to SHARP in 2013 and introduced delayed cord clamping and cord milking as part of a randomized controlled trial. So prior to that, we were pretty much universally doing immediate cord clamping on both term and preterm infants. And then in 2015, we did 2 additional randomized trials. We were trying to ventilate babies on the cord, both for term and preterm babies. For the preterm babies, we did 60 seconds, and then for the term babies, we were doing 5 minutes. So by 2017, we were getting more comfortable with delayed cord clamping for longer durations, but they were still under research protocols. And then really went in 2017, when ACOG came back and said delayed cord clamping was recommended on term and preterm babies, my obstetricians agreed, and we all decided to create a formal institutional-wide policy to attempt to do 60 seconds on all deliveries, both term and preterm, and only in the situations where we can't do the delay, we recommended milking the cord 4 times, as we've done in our preterm trials. So that's sort of where we are. You can go to the next slide. As far as documentation, we use Cerner here at SHARP, and so we had created back in 2013, really for helping us with research purposes to collect delayed cord clamping, whether it was 30 or 60 seconds or greater, to look at compliance, and whether cord milking was performed. This was all done by nursing. It was a challenge to get our obstetricians to document this, but just in the last 2 months, through multiple committee meetings, obstetricians have agreed to take over the documentation. And one contentious issue was getting the breathing portion, but they finally have agreed. They were sort of under the feeling of, well, we don't really assess babies, we don't do NRP, but you know, we were sort of pushing them to say, look, this is an important outcome for us to know if the babies do breathe, right, based on some epidemiologic data, that this would be an important outcome to see if the babies had a better outcome by crying before the cord was clamped. So that is now going to be part of our documentation. So hopefully this should roll out in the next month, and then after we have a year of data, and then we can start building that in. I'm assuming, I know when Henry presented those slides, we didn't document the breathing portion, but I'm assuming that data is coming in from the other sites, because we haven't been, but I know you guys have been asking for this for the last 2 years. So hopefully we can add to that database with our babies. Okay, next slide. So this is the 3 SHARP system. So just to give you guys background, Sharp Mary Birch Hospital is a level 3. It's sort of our hub center. Sharp Chula Vista is a level 2, and Sharp Grossmont's sort of it's a level 2-3, meaning they take some babies under over 28 weeks and do some ventilation, but any babies under 28 weeks are transferred out with maternal transports as well. And so it sort of gives you an idea of where the regionality of these centers are. Sharp Grossmont Hospital is in the orange line, and we sort of sent these benchmark targets when we started collecting data, creating like a friendly competition with sites. Can we all achieve the 70% goal? And so this is for just looking at babies getting at least 30 seconds of delayed cord clamping. And you can see all 3 sites have been inching upwards. And the goal is to sort of at least get 70%, if not higher. And we sort of play with those targets year to year. Then you go to the next slide. This is my real target, which I think true delayed cord clamping is at least 60 seconds. I'd love to get to where Priya is at 3 minutes, but right now, for all babies getting at least to a minute, and you can see here, we're still a little bit short, but we're trying to get to the point of getting close to 70%. And one sort of caveat I'll say here is I believe at Chula Vista, the delayed cord clamping is probably higher, but I think because these are nursing documented interventions, it's probably not capturing it as much. So I think now having the obstetricians documented there, since they're the ones doing it, the numbers hopefully will become a little more accurate, but at least gives you an idea of our trends. And then go to the next slide. Now, I know you have to kind of read this sideways, but this is sort of the only way I could get this on here, is that this is the percentage of infants with cord milking, because we are doing some cord milking here. You could see that in the purple and the pink are sort of Mary Birch and Chula Vista are doing a little more cord milking, around 20 to 25%. And these are obviously babies that don't get delayed cord clamping or aren't eligible for. And again, we'll sort of see how this rolls out over time. And the goal of 70% is not that we want 70% of all babies to get cord milking, but we want 70% of the babies who aren't eligible, i.e. the obstetrician feels like the baby can't get the full delay, that all those babies get cord milking when they can't get a delay. So in fact, we're eliminating, which was our goal, of any babies getting immediate clamping. And then the next slide has some of our numbers to give you, oh, I think I skipped that slide, whoops. Okay, I had a slide in here now. So I was gonna spend the last 2 minutes, I know this is a 10-minute talk. These are the two studies we're doing that may continue to influence how we're moving towards one practice or the other. This is our non-inferiority trial. We're comparing milking versus delayed cord clamping in preterm infants. And again, the idea is not that milking is better, but could it be used as a secondary option? Because I think many sites are still milking the cords when they can't do a delay. So we're trying to determine whether milking is at least non-inferior to sort of the best practice of delayed cord clamping in 1,500 babies. So that's our current trial, which we're currently close to 500 babies for. And then we have a new trial, and I can show you that on the next slide, which is milking in non-vigorous infants. So we're looking at term infants that are near term or term that are depressed at birth, i.e. poor tone, not breathing. And again, this is another area where delayed cord clamping is challenging, where you're not able to keep the mother and the baby connected for 60 seconds. Well, could you milk the cord? And would that have any benefit to cutting the cord right away and reducing NICU admissions or deaths? And so this is another study we're doing with 10 other centers as well. And that's really, I think that's my last slide. Is there one more there? Oh, this is how we're doing the study, essentially crossing over, where for 1 year, the sites will do either milking or immediate clamping in only those non-vigorous kids, and then they'll switch over for another year, and then we'll do 2-year follow-up on these infants to look at how they do neurologically as well. Because even if milking doesn't reduce hospital admissions, but if it provides extra blood and stem cells to these babies, maybe they could still do neurologically better than just clamping the cord right away. I think that's my last slide. Sorry, I don't have the deck in front of me. Yep, that's it. I guess do I take questions, or do we just sort of keep going?
I think well, for the interest of time, can you hear me okay?
I can hear you great.
Okay, great. We can save all of the questions and comments to the end, but I know that Vivian is on the phone, so I don't know if you have anything else you wanted to add.
Janella, the only thing I have probably on the nursing side are current challenges, with the study or the results, if it's done or not done, because like a few of our observations will wait to do the DCC on newborns who require more than the initial steps of resuscitation. And we also observe that there's no consistent placement of baby while they're waiting to clamp the cord. And so, but Dr. Kateria is saying that because it is the task of documentation is placed on nurses, but sometimes they're busy of doing other tasks and they could not observe the physicians on how long they clamp or they're gonna wait for the DCC or milking. So it's not captured in the documentation. And then I guess, I think most of the nurses, I'm not sure how they are, like especially the L&D nurses, how they are educated in their orientation, that this is an important documentation that they have to do. And then on top of that one, even if it's not done or not done, there is no further documentation why the DCC or milking was not done. This is the only thing that, we can observe as sometimes, we attend deliveries and as we get the data, because we don't get everybody like the pilot study that I did for just the Chula Vista eligible CPQCC babies, we didn't have a lot of captured documentation that it was done. That's the only thing for the nursing side.
Okay, thank you, Vivian. And again, for everyone that's called in, if you have any questions or comments, please post them in the Q&A section, and then we can cover that when we get into the discussion. So thank you, Dr. Catherine and Vivian. Now we're going to move on to Cedars-Sinai. And Christine, I'm going to go ahead and pull up your slides so that
the sound's kind of cutting in and out for me too, but can you guys hear me?
Yes, we can hear you perfectly. Is that better? Can you hear me better now?
Yeah, I can hear you. It was cutting in and out of the last presentation, but I think it might just be my sound.
Okay. All right. All right, and here are your slides.
Okay, hi everybody. I'm Christine Galsam. I'm the Senior Data Control Coordinator at Cedars-Sinai. I took over last year for Sandy Forbes, who you guys might know. She was here for quite some time, and I took over when she retired. You can go to the next slide. So thanks for inviting us here, by the way. This one's going to focus more on the actual data collection, which is the part that we do. I put a little bit about us on here. We are a regional level 4 NICU. And I've also added some admission statistics for our hospital so you can get an idea of our volume. This is an average over the last 3 years from 2014 to 2017. So we have about 6,669 live births, 827 NICU admissions. We have an average of 11.9% inborn NICU admission rate, and then we submit about 275 patients to CPQCC each year. Next slide. So the first thing that our NICU did in order to implement the delayed cord clamping was to review the articles and the evidence that supported the benefits. From there, our workflow, since we were part of the pilot, was mostly guided by the delayed cord clamping tip sheet that CPQCC sent out. The leaders of the delayed cord clamping initiative presented the research and the data collection plans at different meetings. So, for example, they went to the pediatric meeting, the perinatal meeting, which is our multidisciplinary meeting for NICU, L&D, and anesthesia. And they also presented at the MD-RN collaborative. And they established delayed cord clamping as standard practice of care. We then went to EIS, which is our tech team, you could say, and we began development of the EMR tool that we would eventually use for data entry and data collection. Our hospital uses Epic, and we actually added the delayed cord clamping variables as a tab within the mother's medical record. We thought it would be best to have redundant data entry. Luckily, both our OB teams and NICU teams were really on board with the delayed cord clamping. So now we typically have 2 places where delayed cord clamping is recorded. The first one is in the L&D delivery note, which translates to a delivery summary. And then the second is in the pediatric delivery room note. And I will expand on both of these in the next couple of slides. So you can go to the next slide. So as I mentioned, our first resource for data collection is the L&D delivery note, which is within the mother's chart. This is more RN driven and is used as our primary source of data collection. After the mother delivers the baby, a baby's info tab will automatically be generated. Under this tab, there is a specific section that says cord. And this is where the delayed cord clamping variables are listed. It's basically a click feature, and it shows up almost exactly as you see here on the slide. So it'll say delayed cord clamping, and then yes, no, unknown, cord clamping, and then various times. And then the nurse basically goes through and just selects the appropriate answers. And then this creates a complete delivery summary, and then the OB goes over it, completes the attestation for it. Next slide. The second source is the pediatric delivery room note. This is more MD driven and can be found in the babies chart. It's a free text and is completed by a hospitalist or the neonatologist or sometimes a pediatric resident, whoever's called to a pediatric delivery. And they mostly mention or format their statements like how you see here. So baby delivered with spontaneous cry, delayed cord clamping times, and then however long. Like I said, this one is a free text. So, and the MDs will usually only comment whether or not delayed cord clamping happened and for how long. They have yet to really incorporate anything about milking as of yet. Next slide. So some of the challenges are that in order for performance improvement to occur, there's two outcome measures that we really would like to optimize here. The first component is the percent optimized of delayed cord clamping. So this is the clinical aspect of it, and it's mostly dependent on our MDs. So what this means for us is, did appropriate delayed cord clamping management occur? Did the right thing happen in the delivery room? Was delayed cord clamping performed in the correct situations? The second part of it is the percent of CPQCC births with the appropriate data capture. So of the CPQCC births where delayed cord clamping occurred, what percent were we actually able to record? And that goes along with the next point, which is that occasionally the questions in the chart will be left unanswered, or it will be filled out only partially. So they'll answer the first two questions, but not the last, etc. The other challenge is that occasionally, since there are two sources, there are variations in the length of time that is reported between the two. So I have yet to encounter a situation where one note will say delayed cord clamping happened and the other will not. It's almost always like one note will say 30 to 45 seconds, and then another note will say 60. But luckily, if they're both within the same time frame that CPQCC is recording, I feel pretty confident in answering that portion. Next slide. So moving forward, we do have some ideas for improvement. The first would be to maybe put a soft stop within the EMR so that when the RNs are completing the chart, there will be a warning or some type of reminder to fill out the delayed cord clamping section. Another thing we'd like to do is to just continue the discussion at the multidisciplinary meetings or the MD-RN collaborative for the need of tracking the delayed cord clamping information and making sure that all of the clamping questions are completed. And finally, I'd personally like to meet with the hospitalist and neonatologist to discuss the possibility of charting the additional data that they don't yet comment on. Like, as I said, they do say delayed cord clamping and for how long, but maybe in the future they'd also start adding information about milking. And that's all I have.
Great, thank you, Christine. Okay, so we're going to go ahead and move on to the next presenter. Let me go ahead and pull up your slides. This is for Adventist White Memorial. Okay. All right, Eileen, take it away. Hello, Eileen, are you on the line right now? Oh, you are muted. Okay, I'm going to unmute you.
Okay.
All right, go ahead, take it away.
Okay. Hi, everybody. I'm Eileen, and thank you to CPQCC for inviting me to speak on behalf of White Memorial. So I'm going to basically talk along the same lines as Cedars. and look at it from kind of the nursing and data abstraction view. Next slide. So just a little bit of background about our hospital. We were founded in 1913, so we're like 5 years old now. We're overall a 353 bed unit, not-for-profit, faith-based teaching hospital. And I wanted to just make sure everyone knew that we were a teaching hospital, because we do have, although we don't have pediatric residents, we do have OB residents, which is probably a key point to how we do delayed cord clamping here. Next slide. So our NICU was founded in 1978. We're a 28-bed level 3, and we admit about 650 patients a year in our NICU. In Adventist Health, we are one of, I believe, 4 NICUs in the state of California, and we at White are the largest NICU in our system. We do have high-risk OB. They deliver approximately 3,500 deliveries a year, and they do have a medical residency program. Next slide. So we started, delayed cord clamping really wasn't a new concept to us, because like everybody else, I'm sure, we did start delayed cord clamping around 2010 with the preemies, and it was about a 30-second delayed cord clamping. So that part of it wasn't too much of, it wasn't a change for us. What was a change was in 2017, probably at the beginning of the year, when we went to all infants. And what we did was, basically I attended one of the CPQCC data trainings, and there was talk about the pilot project. And I came back and said, okay, guys, this is what's going on, and I think this is where we need to move. OB was a little hesitant. There were a lot of people who were hesitant, like, what do you mean all babies, and how are we going to do that? For the most part, up until last year, we were on paper. So it was pretty hit and miss whether or not I got the information if there was delayed cord clamping, because it depended on who the physician was, if it was a resident. So there were some challenges there. But we did basically what Cedars did, and we followed the tip sheet, and we started the ball rolling early last year and joined the pilot project. Next slide. So there was department notification. We do have a lot of meetings here, a lot of separate like unit-specific meetings and department meetings. So we do have a lot of communication between OB, neonatology, pediatrics, and so the initial meetings were all about, well, let's see what the research, what does ACOG say, what are the recommendations, and then how are we going to move forward with all babies. Of course, there was concern about the bilirubin and things like that, and so once we started, we did start looking at trends to see if there was a rise in babies with higher bilirubins, which I'm happy to say as of right now, we have not seen an increase in that. I did present all the data, supportive information on delayed cord clamping. We did work on getting buy-in from all our key stakeholders, like the medical directors, nursing, OB physicians, the residency program, our neonatologists. I'm very lucky that I work with a lot of physicians who are well-read and researched, and so there wasn't really a problem as to moving forward or not. So everybody kind of jumped on board. The problem was with our documentation, and so we did work very closely with our EMR team to add a section in our charting, in our computer system. We use Cerner here, and so we had to work to get that documentation added into the electronic medical record. There is still duplication. The doctors do write a note in the electronic medical record, which is free text, and the nurses do document in Cerner, and I'll get into that in a second. I wanted to bring up our simulation center. So we do, when we onboard new nurses and new physicians, attendings or residents, they do go through the sim center, and we do training with them for delayed cord clamping. So next slide. These are the data points that CPQCC collects. I'm sure everybody's familiar with them. Next slide, Janella. What we did was basically take that information and add it into our Cerner system. And you can see that the questions are basically the same. There's drop-down boxes, and they go ahead and the nurses document in the EMR. Next slide. So I did mention our SIM center. We do have a SIM center here. It is a multidisciplinary training center. So the OB team, and it's mostly the OB team, doctors, residents, nursing, and physician residents. Any new employee goes up there and they actually practice and simulate delayed cord clamping so that when they get into that situation, they are familiar and know what to do. They practice, obviously, the delivery, and they also practice with the electronic documentation. So that process has worked really well for us. You do have the occasional nurse who forgets to document, but that is more of a individual accountability piece versus an education piece. So they're all taught one way about how to do things, and that has really helped with data collection and making sure that we collect all the points that we need. I think I have one more slide. Next slide. So moving forward, opportunities for improvement. We obviously we meet every month and we work with OB on not only DCC, but a lot of other projects. So we're continuing to do that. We are trying to move toward the 2-minute DCC. It makes some people nervous, but again, they're practicing that in the SIM center, physicians, nursing, and the NICU team as well. And so hopefully we'll be seeing that change coming soon. And then obviously data collection and for process improvement is always one of the things that we look at. And so we're always looking at the data, pulling it up, seeing where we can improve and how we can make changes to make things better. I think that's it.
Great, thank you so much, Eileen. Okay, so now is the time to open it up for more discussion and or questions. So if you have any questions or comments you'd like to bring up, now would be the time to do so.
I have a question. This is Anoop. Going to the last presentation, Eileen, have you guys given thought of how to train providers to do cord milking when they need to use it? Because those are the probably situations where there's more anxiety and urgency for the baby, and maybe it's not done as correctly, or?
Our OB team hasn't really moved forward with cord milking. That's been discussion between OB and neonatology. So no, they haven't really been through the milking part of it. They're really focusing on just the straight DCC with not the milking.
Okay, no, I saw that you were collecting that data on your Cerner note, but.
Oh yeah, we are, but as far as the milking, or you mean having the residents or the doctors document in there?
Yeah, well, I saw that was a variable. So does it occur at all at your site, or it never happens?
It never happens.
Oh, I see. Okay. I wasn't sure in those cases when they're not doing a delay if they're milking.
Yeah, they're not milking. Not yet, anyway.
Yeah, no worries. I understand.
Yeah, no, it's Henry. I didn't show that figure, I think, on variation of practice in terms of milking. But as you might expect, that's quite varied, and there's a lot of centers that aren't doing basically any, right?
Yeah, and I think that's acceptable because that's the recommendations. But if centers were, I would worry about how do we train people to make it more standard, because the beauty of delay is there's not a lot of technique that needs to happen. You just leave the baby alone and stim them. But for milking, it's sort of how you do it, et cetera, that could be more problematic.
Yeah, absolutely. And actually, I really appreciate, Eileen, that you mentioned the simulation aspect, which could perhaps address if it moves to that in some centers. it seems simple enough in sort of theory, but you do sort of need to learn how to do it and practice it, I think. So perhaps some simulation model could help with that. I also like, Eileen, you said that you simulate the documentation.
We simulate both the delivery process, the milking, and then after the documentation.
Yeah, not the milking, but the delay.
I mean the delayed cord clamping, sorry.
Yeah. No, I really appreciate that. I think just trying to do everything that you actually do in real practice is really helpful when you do simulation.
Yeah, our sim center has been a huge plus here, and OB is in that sim center all the time.
Yeah. So yeah, folks, feel free to type in a question in the chat. I appreciate all the presentations. I think they're really great. Yeah, it's really interesting to hear how each center's implementing and dealing with challenges. Anoop, I might have one question for you actually. You mentioned about you got the OBs to agree to document, and you talked about a little bit, and I imagine it's kind of just asking nicely and telling them the reason. But any other thoughts on that sort of process? How other centers could maybe get their OBs to get on board? And the other thing too is it's not really more about documentation. You're really asking them to assess the baby, I think, which seems quite appropriate. They're right there, and it's in many ways that's what they probably used to do back in the day. We didn't used to be around as much, and so they were really the ones responsible for the baby. So yeah, any thoughts on that process of getting buy-in, I guess, for?
Yeah, I mean, the argument too I've tried to make is that since they're the ones assessing, like you said, when they're deciding whether that baby can get a delay or not, we were just making the case that nursing can often get a good assessment of that baby, especially that breathing part. And then when I sort of pushed that, look, that may be based on some physiological data, the most important thing. The most important benefit for the baby is that establishment of breathing, and it may not even be a time. So we're sort of stressing them, look, if you can, get that baby to start to breathe and then document that piece, that's critical for us to know that the baby could be much better. And I think they've sort of, it's like the last few speakers, that sort of education piece of them understanding that is probably great. We've sort of tried to illustrate that through a couple of figures and diagrams about where we think this blood's going and that sort of piece. But I think putting it, really helping them understand the benefits of that it's a benefit to the baby. Remember that some OBs are still dealing with the old mantra that, oh, this is just about giving them more hemoglobin or preventing anemia, but we're trying to talk about more than that, about just transitioning the baby. Maybe the baby could do better and stay with the mother. So trying to argue for those benefits with delay clamping or milking, et cetera, I think is the way to educate them. It's not a blood transfusion issue. It's a transitional issue. So.
Yeah.
Absolutely. And this is Eileen. I just wanted to add that, and I should have put it on a slide. We do get transports in from smaller community hospitals, and that has actually been quite a challenge because you do have some of that old school thought out there, and they just practice a little bit differently sometimes, and getting that documentation is hard. So we're really doing a lot of work with outreach right now to try to get everybody on board. So it's been a little bit of a challenge.
Yeah, this is Vivian. I have a question. As we move forward to possibly a 2-minute DCC, is there an education piece for the OB to how to hold the baby? Like a consistent placement of the baby while they're waiting to cut the clamp? Is that variable, or is that an important thing for them to do? Not, like some would put it on mommy's abdomen while waiting for the cord to be clamped, or they can just hold the baby for the 2 minutes before they could clamp the cord.
Are you asking Dr. Lee or me?
Yeah,
Vivian?
Dr. Anopia, would you? I mean,
me.
Like
yeah, we're not going to document, it'd be fine for other sort of looking at things, but no, there's been studies showing that definitely for vaginal birth that placement of the baby overall, especially if you're going 2-3 minutes or longer, doesn't really make a difference in the amount of, they looked at weight of the baby and that in fact, the blood transfusion, the amount of blood the baby's got was no different if they held them lower or higher. So
I see.
that was a paper in Lancet a few years ago. So the argument of, you know, and this was a big L&D issue, and it's, I'm sure the other centers on the call too, is the immediate skin-to-skin need. So it made everyone much more relaxed that, oh, I could put the baby on the mom's abdomen and still do the delay and allow that to occur rather than trying to hold this slippery baby lower. And if you want to go longer, it makes it much easier so the OB doesn't have to control the baby. So at all the Sharp hospitals, Vivian, we're telling the obstetricians to put the baby on the mom's abdomen, and that's fine, and try to go at least a minute. We're pushing for longer, and some OBs are greater. We're not standardized. I think Santa Clara, to my knowledge, is the only place that's standardizing like a 3-minute delay, but I think we're just going as long as possible, but at least aiming for a minute.
Okay, thank you.
This is Priya. I have a comment as well. Great presentations overall. So the question about, I would echo what Anup just said. So I think as long as the baby is breathing, that is the more, that's the key indicator of how your transition and the flow is occurring more than the position of the baby. And I agree. I think moving towards putting the baby on mom's abdomen more and more, especially for those who are who have a long enough cord. So essentially, like, you know, babies who are like 31, 32, 33 weekers, and definitely the cord can be long enough for you to get the baby and leave them on the maternal abdomen more than anything. And I think, you know, and that's been our practice as well. I think people get so, the less we can specify, like, oh, you have to do this, you have to do this, like keeping it very simple as to keeping the baby, getting the baby on mom's abdomen if the cord is long enough, if not, hold the baby close to the maternal introitus, has been made it easier to communicate our intention for the delay. You know, I think the more little things we try to micromanage, I think we lose the big picture then. One thing, you know, it's great to see so many centers doing so many things in terms of standardizing, you know, documentation and the simulation in particular. I was going to add one comment about simulation on the milking. I agree with Anup in terms of like the milking, the procedure of milking. If we get 10 OBs and 10 residents in the room, each one does very different things. So what we had to do for our center, and you know, our center standard is we would go for 3 minutes. We'd give at least 30 to 60 seconds for every baby to provide them, give them the opportunity to take their first birth. And if we can't, then we ask them to milk the cord. One of our OB chief residents actually made a video of the correct technique of milking to share it with his own team, so that when we had to do milking when we couldn't do those 3 minutes DCC like how we intend to do, then we do recommend, we do ask our OBs to do milking. But I think, like, you know, along with simulation or even video or different methods, especially for residents, it's really helpful. And almost teaching the residents kind of helps us standardize the teaching for attendings.
Yeah, that's great. Yeah, that's a great, awesome suggestion. Is that video, do you have like with that video online for people to view publicly, or?
We don't have it online to view publicly, but I will actually, I'll talk to our OB resident and see if we can get that online.
Yeah, or we could even host it on our website.
Right, yeah. I had a question for Anup. Anup, it's so nice to see 5 minutes for term babies. I had a question for, so in your center, what is happening to the C-sections with the longer duration of DCC? Are OBs comfortable?
Not all of them. Most of them are comfortable with at least 1 minute and not having a problem. If the babies are fine, I would say the majority of them only do a minute, but that was a study. So we were trying to do, you know, resuscitating babies on the cord and going at least 5 minutes in term infants. So that sort of pushed the envelope they'd never seen 5 minutes, many of them before. But for our center as a private hospital, one of the nice things is because, you know, we don't have that top-down method where you have a division head and says, look, we're going to do this and everyone needs to follow. We have OBs that can do whatever they want. But the study, being in a research study first, I sort of feel like pushed them to say, okay, we have to follow this protocol. This is a consented mother. They would do it. And I think that 5 minutes of them experiencing that and having to wait and knowing that's part of the study, I think made them more comfortable going longer. But I'm not going to sit here and say we do 5 minute delays at section. I haven't seen anyone go that long, to be honest. And I just think we just have to get more comfortable. One of the things I know, I talk to a lot of centers that are doing this as far as the studies, and I think more obstetrician involvement with the longer delays at section would be key, because the one risk factor, when we just wrote a retrospective paper on this, is looking at postpartum hemorrhage and bleeding at cesarean section with prolonged delays, because this was a study of multiples where each baby got a delay, and they sort of saw the longer that delay was, there was a slight uptick. And I think that could be an obstetrical issue that could be managed if OBs are aware of when they're cutting the uterus, looking at bleeders. And again, you guys are great, so I'm sort of preaching to the choir. I'm sure your OBs are managing that, but other centers, if they're going to adopt longer delay, just have to be more mindful that their OB is paying attention, because all sections have bleeding, but it's usually insignificant. But if we go longer, I think they just more mindful of that. And I think then we can get to that longer approach of going at section.
Yeah, no, that's great. I do, it's impressive what, the slower extension of the duration actually has been helpful. So I think what has been helpful, at least for the teams for us, is that giving the OBs or recommunicating, in the beginning of delivery, like, we will tell you from a baby standpoint when we would like you to stop the DCC. Otherwise, we assume and we would like at least 3 minutes for every baby. And then you let us know about the bleeding part. So we actually recently had like a set of triplets. So particularly a comment about the multiples. Two things. One is, probably years ago now, some of the OBs, especially actually our perinatologists, they started with the multiples actually delivering, if it's twins or triplets, getting all 2 or 3 of them out of the uterus so that we can observe from the baby standpoint. So often the duration of 1 minute or 2 minutes per baby in the multiples is not necessarily additive. Like it's not 1 minute for the first baby and then 1 minute or 2 minutes and so on. Often it's simultaneous. So the most recent set of triplets that we had, I think from the beginning of the first baby's delivery to the clamping of the last baby was about 4 minutes and 50 seconds.
No, that's
while
great.
Everyone got 3 minutes. But yeah, our OBs are very vigilant about bleeding, and they know that, we would, that they could clamp the cord whenever they think that the maternal postpartum, when there's a concern about hemorrhage. And the other thing about the estimated blood loss, I think one of the things our center is moving forward with is actually doing a QBL, or like a quantified blood loss versus an estimated blood loss. Like they have developed some standardized technique. And I think that was introduced either late last year or beginning of this year. So we feel like that has also been very helpful, because otherwise the estimated blood loss is so variable. In one of our residents' research, what they showed is like you can overestimate by 30 to 50% or even more when you do an estimated blood loss compared to the QBL. So I think, yes, I agree. I think having all these discussions together, and it really, I think one thing that the OBs feel is, as long as they feel like they have the freedom to do whatever it is necessary for maternal, for mom's safety, makes them feel better, rather than this feeling of, oh my God, because of this institutional desire to do DCC, now I have to put the mom's health at risk, which is never the case. It's in optimal settings, this is what we want, but always feel free to, cut short if you're concerned about the mother, and we say like, we will do that if we are concerned about the baby as well.
Good point.
right. It's been Grace asked a question online of do we need to change our categories? We debated quite a bit actually in the beginning what the categories are for the duration. And Priya, I think we've also talked about is even 30 seconds, should that be considered DCC? And ultimately we have flexibility in how we show reports. So I think we decided that, there might be a few different ones. And like I mentioned at the beginning, we don't have much yet, but over time, as we get more data, we'll be able to show, some of this as a quality measure. But I'm not inclined to have a separation, because right now I think our longest duration is like, what's our longest duration, Janelle? Is it more than 1 minute or more than 2 minutes? Let me check. At any rate, I think, because some of the centers are pushing it a little bit longer, there could be a rationale for creating more categories. I'm not inclined to, I think, suggest that as of yet, because there are many centers that are still really trying to work on just even getting a good amount of their babies to 1 minute. So
we have greater than 60 seconds.
Yeah, that's our current longest duration, I guess. But perhaps over time we may, if people request it, consider having like 1 to 2 minutes and greater than 2 minutes, I suppose. I think I appreciate, Christine, you acknowledged the tip sheet that we have, which came out of really a lot of these initial webinars, and with Priya's help and others who sort of chimed in on what they've done to help things. I'm wondering, so we have a fair amount of sort of materials for folks who might be just starting out. Do we think there are any gaps or in terms of other tools that we could provide? I feel like we have enough now, because there's a lot of educational materials too and references that folks can use to, for example, to bring to team members, whether it's OB or other team members who are still learning about the scientific evidence. We have some implementation tools, and then we have recordings of all of these webinars as well for those who have the interest to try to learn from what other centers have done. I think we have sort of said that this will be our kind of last formal webinar on this topic, because we feel like there have been a fair number of resources that we've been able to gather and provide. So as we sort of end, I guess, this phase, I think if any of you have further thoughts on other sort of ways that we could help centers to implement things, then you can let us know, whether it's now or in the future. But yeah, I really appreciate everyone's efforts in this project, and also for today's webinar, it's adding, I guess, again, to the resources that we have. So really appreciate it.
Henry,
Yeah.
I would like to actually acknowledge and appreciate your thoughtfulness in initiating this project. I think, as CPQCC, this is a great, I know there was a lot of the way initially how this pilot got started, it was a great way of initiating. The biggest concern about the data collection piece being very complicated for a variable like DCC. Clearly, it seems like when there is will, there is a way. It's we can see such great work among different centers who've been able to successfully collect data on DCC. But one question I have is, so what's the next step for CPQCC? So the DCC is going to be a mandated data as of January 2019, correct?
No, it's been mandated this year, actually, in 2018. Yeah, so of course, it's still, the middle of the year, I suppose. So we don't have we showed some of the preliminary data. That's sort of for 2018. That's sort of preliminary. but we'll have to see what it looks like once it comes in and it's finalized, sort of get a better idea of the picture across the state. And as was noted too, the data quality, I think, is probably, again, as with the pilot, going to be the main issue initially for some centers who just started in 2018. And so it will take, a little bit of time for us to get a full picture and see the gaps, and perhaps there could be a reinitiation of some efforts to then, help people to further their work on this. I do think, though, that because of ultimately, because you're prodding Priya to get this going, even though it's taken some time in the end to get started, I feel like we're really ahead of anybody else, in terms of large organizations that are actually even collecting data on this. So I'd like to see what we can do to then now work on the, actual, I guess, quality improvement implementation even more in the coming year.
Yeah, no, this is great. And then just to follow up on your comment, on the previous, the question about the 60 seconds now, do you think is it time for us to change and expect that at least 60 seconds would be a minimum to consider somebody as having DCC?
Yeah, no, it's a good question. I know we've talked about this, and I think we can show it that way in our report eventually, once we actually implement the reports, sort of as a quality measure. I am not sure, though, like, because even at Packard, for example, where we're like really behind, I suppose, for some folks, I feel like they think they might consider like 30 seconds even to be at least the intermediate goal. And I'm not sure. It's probably a little bit of behavioral psychology too. So if you allow that to be a goal, is that sort of causing them to not reach sort of the full potential? So probably, I'm not sure. I think it might warrant some further discussion. And I'd like to get feedback from probably, a bunch of our membership sort of stakeholders to see what they think about that.
Yeah, I think that would be great to get that. So the only thing I would say for us is, moving our targets from 1 minute to 2 minutes to 3 minutes. It's really, when we decided to go to 3 minutes, one of our goals, one is, to provide the best benefit for all, but the second thing is to really say, well, if we put our target at 3 minutes, maybe everybody will get at least 1 minute. And when we looked at all deliveries, so, not just the CPQCC, so we have about 3,000 to 3,500 annual deliveries. And what we noticed is, when we looked at what % of babies actually got the 1 minute DCC in 2015, 16, 17, and 18, as we furthered our target, actually more babies got the 1 minute DCC. So for now in 2018, as of year to date, like as of end of July, 95% of our all deliveries have gotten at least 1 minute, while 75% have gotten 3 minutes. So in a way, in our minds, what we've learned, and we wouldn't have anticipated this, but what we've learned is it really took us like pushing the target duration to ensure that almost everybody got the benefit of at least 1 minute. So that's just our experience.
Yeah, well, that makes a lot of sense, I think. Yeah, and so I appreciate that insight. Yeah, and basically everybody knows now who's like on that right side of the figure driving, increasing the average for California, right? But no, I think, yeah, we'll think about how we, because I think we're still learning a little bit of what are the right data measures. I think for the initial period, we wanted to have a consistent, variable in data collection, but we probably still have time to, or room to evolve that as we learn more. So we'll think about the duration, that question, what might be optimal, and we'll reach out to some folks in our committees to get their feedback.
Yep. No, and thank you everyone for the opportunity. I mean, this has been a great 3-year journey of all these webinars, and definitely thank you to Henry and Janelle for the leadership of getting all these webinars. And we've actually also learned quite a bit from all these centers who presented over the years in terms of all their experiences. So this has been a great learning experience for us as well. Thank you.
Yeah, thanks, Priya. And so, yeah, I think we can probably end now. And even though, as we said, it is sort of our last formal webinar, I imagine that we'll have something else in the future as well, as other centers get even more attuned to this. And even though we have these online resources, I think perhaps as the need arises, we might ask some of the panelists again, and Priya, you as well, Anoop, as you're doing a lot of great research in this area too. I think we're learning more. So I think we'll try to find perhaps another forum over time to advance this agenda even further. So, but at least for now, I think want to again acknowledge Janella for doing such a great job organizing this from the beginning. And she's still going to be, I think, the main contact if you have further questions or suggestions on ways that we can, advance things further. But otherwise, I think we'll call it a meeting, and thank you all very much for participating.
Thank you, everyone.
Thank you.
Thank you, everybody.
Thanks, Henry.
All right.
Thank
Bye.
you.
All right.
Thank you.